Well, thank you again, Subhash. Wow, what just a great series of lectures we've heard so far, and a number of points have already been made. So it makes my talk, even much more easier. My disclosures are seen here. So, coronary imaging and physiology. Why do we continue to pay attention to this? There are several reasons, and I'm going to go into this in a little bit. But you just get a much better understanding of the coronary arteries. The anatomy, the pathology, the complexity, and it just helps us do a better job with revascularization. And that's going to be the key. If we're going to remain in this business, if we're going to convince Dr. Jessen that PCI is reasonable, then we have got to do a good job. We've got to show good outcomes. As we adopt new stents, new technologies, we have to be able to implant them well because the poor implant techniques is associated with worse outcomes. These are some of the things you can see with coronary imaging. I'm showing you pictures here of IVUS and OCT showing heavily focal area of heavy calcium. These are arteries that you just cannot effectively dilate with a balloon. And by understanding this, it allows you to move to other techniques that help you degrade some of this calcium so you can expand this stent much better. Here is a patient who presented with what looked like a STEMI, and all we found was, all that was seen was some haziness in the mid-LAD. If you then went on to imaging, either with an IVUS or OCT, what you can see here is a pretty significant spontaneous coronary dissection. So it provides you substantial understanding of the pathology here. Coronary stents, and I think, again, as we move on to these bioresorbable technologies, this is really going to be mandated. We have to image these arteries to ensure that the stents are well deployed, well apposed. Here's an example of incomplete stent apposition. And we can see complications. We can understand complications better. This is thrombosis within coronary stent, and this is dissection at the edge of implanted stent. Both leading techniques for imaging are very well established, and they share a number of very similar characteristics. You can pick essentially either one of these. They both will allow you to size the coronary arteries so that you're selecting the appropriate device for treatment. They'll allow you to determine severity of stenosis. And specifically today, most will agree an MLA of less than 2 to 2.5 for the major epicardial coronary arteries would indicate or is consistent with obstruction. Or for left main disease, an MLA of less than 6 millimeters square. Again, as I mentioned, you can better characterize the stenosis itself, the composition, how much calcium, whether thrombus is a component, lipids are a component, and that allows you to better select your treatment strategy. Importantly, once you begin to treat or once you deploy your stent, the imaging can help you understand whether your stent is well deployed, well expanded, and that will lead to reductions in complications, including restenosis, dissection, and thrombosis. Are there any advantages of either technique, either IVUS or OCT? Well, for IVUS, you get deeper far-field penetration, so it's better for imaging larger vessels, perhaps for sizing, because you can see the internal elastic lamina a little bit better. And then you don't require contrast to displace the blood in imaging, so it's very versatile and relatively cheap as well. For OCT, the near field resolution is fantastic, and you've seen some of these images already. It's great for pathologies within the lumen, such as thrombus, dissection, and stent apposition. And the smaller catheter profile also helps. Now, up until recently, we had no definitive evidence saying we should use imaging to guide coronary stent implantation, or that we didn't have the evidence to show that it improved outcomes. The imaging technique is pretty straightforward. Just a few suggestions that when you do this, you shouldn't complicate the procedure at all. Use a guide that minimizes ischemia, wire the vessel with good techniques so that you don't traumatize the stenosis. We generally give vasodilators and make sure that you have an adequate amount of imaging or pullback so that not just the disease segment but the reference segments are also well visualized. And it's important to go through and make the measurements that are important in improving outcomes. So understanding, again, stenosis severity, the reference segment, how much, what kind of reference segment diameter we hope to achieve with stent expansion, looking at the expansion of the stent itself after it's deployed, and looking for complications such as dissections and hematomas. I'll then move on to physiology with fractional flow reserve. This has now become fairly established based on trials over the past few years. Why is this important? Again, I think we have to be careful how we do PCI. We want to select the patients who are going to benefit from percutaneous revascularization. And ischemia is key. So there are several trials now that have shown that ischemia is really what predicts outcomes. The more ischemic you are, the likely you are to benefit. And the more ischemia you leave behind, the worse your outcomes. Ischemia is, looking for ischemia is a much better correlate than just using symptoms or angina. In addition, a lot of patients enter the cath lab without adequate stress tests, and there are a variety of reasons why that happens. Either the stress tests, the patient cannot undergo an adequate stress test, or it's just inconvenient, or the images are not conclusive. But whatever the case, up to half of our patients, elective patients, do come to the cath lab without adequate stress test information. And with the tool of FFR, we can better determine who is ischemic and who will benefit from revascularization.